Okay, so we are in the cath lab here doing the case of VSD. We have Lucien and Kevin and Gioca there, enlarge the field for a second. And Carmelo Arcidiacono will perform together with Rita and Mohammed the echo, the transesophageal echo. And now Carmelo will show you in very briefly the summary of the case. Please, Carmelo, go on.
Good morning, everyone. Let me just briefly introduce you.
This is case number 10, yes?
Yeah, it should be.
Yeah. Okay, thank you.
Oh, this is an 8.5 years old girl with a neonatal diagnosis of VSD. She suffers from recurrent respiratory tract infection. She's got the typical findings of a VSD with dilated LV on echocardiogram. Next slide, please. And that's the VSD on transthoracic echocardiogram. That looks like a perimembranous VSD with a significant, with a good aortic rim, it looks like.
Yeah, Carmelo and Jacques. Well, the question is whether, Kevin, I'd like to know your comments about the diagnosis of perimembranous versus high muscular VSD.
Yeah, I mean, they've got some really nice echo pictures of it. And I think there's a nice short axis view on the T that I think is fairly convincing for it being a perimembranous defect.
So, Carmelo, why don't you show us the video clips of the echo?
Yeah, let's just start with a picture of the... Can we just have the live echo pictures, please?
L'echo.
No, okay, that's the dilated left ventricle. Then you can just see the perimembranous VSD here. It looks like it's 8 millimeter circular shape VSD. Okay, so you can see the fibrous continuity with the tricuspid valve, and here you have the long axis view in which you can see there is a good muscular rim below the aorta.
So I mean, they're excellent views, and I guess the question I'd ask the
3D, just
audience and panel while they're getting up the 3D images.
Let's have a look at the 3D reconstruction of the defect. Carmelo, please.
Okay, right, let's move on to the 3D, and I can show you in a moment the aortic root. You can see it very nicely here, and that's the VSD below, and there's quite a significant gap between the VSD and the aorta. While if you move on the other side, you can see the VSD here and the tricuspid valve.
Okay, so that's good. We did some measurements, some
the measurements are about 8 millimeters. As you can see, the VSD is circular in shape.
Okay, Carmelo. Well, the QPQS in this case, just to anticipate your question, is very high, more than 2.5 or 3. And Kevin, would you carry on and describe what we did so far?
So we did a very quick right heart and got the saturation stepped up from 80% in the SVC to 96% in the PA. The PA pressure was normal. We then went to do a left ventriculogram, and the pigtail essentially went straight across the VSD. So we took that and did an angio sort of sitting across the VSD, and we'll just show you that angio now. So if we can just switch up to that. It's just about to come up.
Whilst you're finding the angiograms of fluoro, Mario, just a quick natural history question. With that size VSD, an 8.5-year-old, what was the reason for delaying it to this age, the closure of the VSD?
Because we saw this patient for the first time 1 year ago. She was following in other institutions.
Right.
So I don't know whether we can turn the button up just to show the angio. It's We're still on echo. So a little. Just switch to fluoro. I think we're going to see it on this screen.
No.
Is that it?
We can see
okay.
the angiogram at the moment.
So the angiography actually added very little, and you can see on this view we've actually already got the sheath in the LV. We'll just go back one and see how the snaring or the guide wire loop was created.
Vediamo il loop, l'immagine del loop. Ditelo.
Okay. Well, that's a nice echo view of the sheath in the ventricle.
Marta, please. We have to see the picture of the AV loop. Can you see that? Fluoro. Let's see the fluoro.
I think we want fluoro.
Yeah, this is fluoro, isn't it?
Yeah. Okay. So.
Yeah, it's my English, Mario. They understand that better than yours.
It must be that, Shaq.
Yeah, that's right.
We were sort of lucky in that the pigtail with a J wire went straight across into the right atrium and the SVC, and we were able to snare it up in the SVC and pull the pigtail down to the IVC. We were on a short J wire at that point. I sort of was more happier that we crossed it with a J wire. So we snared out snared out a bit of the J and just caught the pigtail and then put in the noodle wire or rope wire.
Right.
And then exchanged over that to get the sheath into the left ventricle in the usual way, going into the aorta and then using a pigtail to push it down into the left ventricle.
That was very easy and quick.
Yeah.
So let's go back to the angiogram or the real-time fluoro and echo. And Kevin,
what size?
You may ask to.
So we put in an 8 French torque view, the membranous device torque view, the 180-degree curved one, to give us sort of a little extra space. Although I guess the devices that we could deliver would probably go through 7.
We've not decided yet about the device. You should ask the Shark and the audience, Kevin. Yes.
Yeah. So the question I was going to ask was, have you got a clear idea of the size of the defect from the 3D or from the 2D TOE?
Of course,
we think 8 millimeters, fairly circular, but really quite a high.
It looked like a funny. It looked like a funny circle from the pictures we saw.
You think it was a squashed oval, really?
Yeah. So which direction was 8 millimeters?
Well, they felt it was pretty circular, but it does look. As you say, it's a
let's
squashed
enlarge
circle.
the echo picture.
Yeah. We can have a look again.
It looks like it's pretty round in shape here. Here you see the aortic valve here.
It's nice picture, isn't it?
Yeah, very good. So I think you're right. It's not a circle. There is a long axis and a short axis, and that's always going to be the case with a VSD.
Sizing and selection of device size is crucial here, isn't it? So you need to have a clear idea of the circularity or whatever the word is and the dimension. Question from the audience or comment?
Okay.
Yeah. Go ahead.
Yes, good morning. I just need to ask a question.
We can't see you. So,
it's Rasha Ammar from Cairo.
Okay.
From the size of the LV, it looks like usually with this size of a perimembranous VSD, you would see a biventricular enlargement rather than a huge left ventricle. Is this somehow suspicious of a coexisting PDA as well? Would you go for an aortogram
PDA.
just to make sure that there is no associated PDA that you would need to close as well?
I know she's had comprehensive echo beforehand and they didn't see a duct, so we wouldn't do that.
Yes. Maybe because of the high pulmonary artery pressure, you would not see a shunt?
Yeah, no, we measured the pulmonary pressures and they were normal.
Okay, so it looks like it is an LV, and I think brief shot of the LV angio didn't show any PDA, but anyway, it's a good point. No. So we're still dependent on the size of the defect before selecting the device, aren't we?
Yeah, that's the crucial thing, and it's often a matter of judgment. You'd like to think that a 10 would be right. I have a sort of a gut feeling that a 12 is going to be better. But I guess we're more concerned with these cases about creating any impingement or effect on the conduction tissue, so maybe going small is good.
Yeah, that's right. Okay. I mean, we both, Kevin and I, are likely to use a muscular VSD occluder, trying to...
Let me, Mario?
Yes.
Just hold on a second. Let me just pick on one or two people first. Carlos.
Yes. Yeah, sure.
Muscular or perimembranous VSD device?
Yeah.
I think you have enough rim up there, and it looks more circular. And I think I would choose perhaps a muscular VSD.
And assuming this is 8 millimeters, and assuming that,
I would probably not exceed it more than 12 millimeters. That would be my highest limit.
Gerald?
Yeah.
12 millimeter muscular, you say?
Ideally, I will go with a 10 millimeter VSD, but I would not put larger than a 12.
Okay, that's an interesting one. Gerald?
Well, I have not that much experience with closing VSDs, but I would rather go for a smaller than a larger device in regard to the conduction system.
What,
yes.
8 or?
The 8, yeah.
8 muscular.
Well, the choices are
8, 10, and 12.
8, 10, and 12. Yeah.
Yeah. Okay. Can I have a show of hands? It seems as if the tendency is to use a muscular Amplats, a muscular VSD device. Those in the audience who would select an 8 millimeter muscular VSD device, judging by the 8 millimeter size of the defect. Show of hands. Hands up. 1, 2. Okay, 3. 10 millimeters. Yes?
Okay.
Okay, that's a
So shall we carry
12 millimeters.
12.
Just very quickly. Just looking for 12 millimeters. Okay, looks like the majority put their hand up for 10 millimeter muscular VSD device, Mario. Kevin.
Well, actually, to be frank with you, we already decided to use a 10 millimeter device, and we are happy that the audience agree with us as well. Yeah, Kevin?
Thank God for that.
Okay, so let's go with the camera to the table here to show you the device. Where's the device?
Oh, we didn't open it, Mario. We were
Yeah.
waiting to see. We were waiting to see what the audience said.
Oh, yes. And what about the
Have
option?
a look on the floor.
Yeah, shock. Nobody wanted to use a membranous occluder in this case?
Okay, well, I didn't. We established that it was going to be a muscular. Anybody in the audience that would use a perimembranous VSD device? Just come up. I can't see you in the dark. Siva, just tell us why you think, what size and why you think perimembranous, very briefly, whilst they're looking for a muscular device.
10 millimeter perimembranous.
Microphone on. Right, go on.
10 millimeter perimembranous asymmetric device. The waist is smaller, and since the membranous septum has got a much shorter septal thickness, I would like to use a shorter waist device. A muscular VSD occluder's LV disc may impinge a little bit on the aortic valve, even though the echo demonstrates some separation.
But in engineering terms, what is the radial force of the perimembranous 10 millimeter device versus 10 millimeter muscular device?
It should be higher, and possibly the chances of eroding the conduction system is higher. But the thickness is the stent length between the two discs is shorter.
Yeah. Okay, Carlos.
I have a question. Maybe Carmelo can answer that, and also Kevin and Mario.
Yeah.
You guys have such a wonderful picture on 3D. Have you ever considered choosing your device based on the area of the defect? Because you can plot the area on 3D, and based on that measurement, you can come up with a specific diameter for the waist.
Yeah, no, it makes more sense, particularly when you've got short axis and long axis. And then you
an oval shape.
Yeah.
Then you'd have to assume for the diameter of the device, you'd multiply by 3, and it would be a simple enough thing to do.
Carlos, let me add a comment on that. The 3D reconstruction of the defects, in my opinion, are very nice to get an idea of the anatomy. However, the measurements we are taking on 3D are not so accurate. So you may take into account that we are more in favor of having an idea of the anatomy, but be careful about the measurement taken from 3D reconstruction. Is that right, Carmelo?
If I can make a brief comment too, it's actually not possible at the moment with the currently available software to make measurements directly onto the 3D pictures. The only thing I can do is to superimpose a grid on the 3D picture. Okay. Every small square, every dot, the distance between two dots is 5 millimeters. So by moving the picture this way, I can actually assess, have an idea of the dimension, but it's obviously not an exact measurement.
That's very nice technique, I think. So, if you don't mind, we will carry on and load the device, a 10 millimeter muscular VSD occluder here on the table. Kevin?
Okay.
You're all right?
Mario, I see you loading the 10 millimeter muscular VSD with the thicker cable, the one that comes with the 45 angle delivery system, rather than the small thinner table pusher that comes with the 180. Why are you preferring that stiffer delivery cable as opposed to the softer?
It doesn't matter.
And thinner. Does it matter to you?
I think maybe in a smaller heart it might matter a bit more. I think it's not going to make any difference here, and it's theoretically simpler that you don't have a pusher, and you don't connect the pusher anyway because it doesn't have the D-shaped connect. But I think you can use both, and we had this debate earlier whether we should just use the one that came with it rather than open a cable from an ASD, and we opted to open a cable from the ASD. But I think I'd be happy, and we've certainly put them in just using the pusher and the other wire. I don't think they're any particularly less stiff, but if you see it pulling the whole sheath out of the ventricle, then you're right.
Well, in our experience, we prefer to use the thinner one.
Okay.
Dobbiamo avere pronto un angelo. Yes. So shall we carry on this?
Yeah, so we'll go ahead and load this. It's nothing special.
We've got 5 minutes.
Okay.
Kevin?
Yep.
Okay.
We've got 5 minutes with you before we go.
Yes.
To
okay. Here we go.
We flash it?
Yep. Okay.
We are ready to go. Yeah. Okay.
You obviously don't soak this in blood.
No, we do that
don't.
inside the body, actually.
Well, yeah, that's right. Yeah. Okay. Okay, we will want to have fluoro and echo simultaneous pictures, please. Okay. Step. And echo, which you want to have a fluoro large or echo large?
What do you want? It doesn't make any difference. I guess
okay.
fluoro large is what we
okay,
use.
Fluoro large.
Okay. Okay, here we go. I guess at this point, what you really want to make sure is that you don't...
you can watch this anyway.
Is that you don't open in the mitral. So maybe just to come back a little bit before you get the disc fully out. So try to open the device more in the LVOT. Whether we can get any echo guidance of seeing the device open. There's just a little ball there at the moment.
Yep.
Yeah, we can see it there. So it's
still very far from the defect.
So we're just going to come back slowly onto the defect. And we're crossing the TOE, but that's pretty common. And we're moving slower into the defect.
Maybe we go a bit more LAO.
A bit more LAO maybe will help. Yeah.
Attenzione ragazzi.
Technical question, Kevin. When pulling back at the moment, do you rotate the sheath in any way, or do you keep it just...
No, it's just a pullback. I think it determines its own course. So we're just beginning to move into the defect.
While you're doing this pullback of the left side already open, do you check for MR? Do you check for mitral regurg?
Well, we can do that easily.
It's a long way away, as you can see there.
It is.
Yeah.
There is no Mitral regurg, yes.
So the question at this point is how much we're in the defect and whether we're in a position to start doing the right disc.
Can we just see echo now because we see you instead?
Oh, no, you don't need to see us at all.
No. Stay with fluoro and echo all the times, okay? You want to see the echo large?
No, we're okay now.
Okay.
Okay.
We just didn't want to see you.
That's okay. We appreciate that. So I think at this point, I think I'm fairly well in the defect.
Maybe
we could do an angio, you think? I don't think we'll learn.
Why don't you do an angio just
Okay. We can come back a little closer then.
Right, okay.
A little closer to it.
A little closer, Kevin, to the defect. Yeah.
Okay. And you ready?
Yeah. Okay.
Probably a slight bit more back with a bit of tension and the release of the RV then.
Yes.
Okay.
Yeah. Okay.
That looked good.
That was very good. Dietmar has got a comment or a question for you. Dietmar.
Good morning, Kevin and Mario. Do you have a special technique for applying the right-sided umbrella to avoid the tricuspid involvement? So, did you start with the deployment of the right side? Still, the right umbrella is in the defect, or do you have any control on this?
I don't think there's a lot of control, but maybe it's something we should be working at, that we make sure the device slips under the tricuspid rather than over.
Check the aortic regurgitation.
But I think you can see from the short axis view that we're under.
Yeah, I will ask. I will ask Carmelo now to do some different sections, echo section, particularly to be sure about the aortic regurgitation or no aortic regurgitation.
Yeah, as you can probably see, there is no significant aortic regurgitation at this stage, despite a lot of tension from the system.
That is not the problem. Sometimes the muscular umbrella with 7 millimeter stent between the umbrellas is a little bit too long, that you have not to involve the tricuspid valve.
Okay. Well, the tricuspid valve is not involved. Dietmar, I think we are ready to release the device.
Yeah, wonderful. Yes.
Hopefully, you don't need any special projection to release the device, right?
Caudal.
Is that okay for you?
Let me just check the tricuspid valve again.
Yeah, really unfair.
Okay.
This brings us back to the point. You go ahead and release it, but it brings us back to the point that Carlos made about the cable.
Yes.
Because if you are slightly unlucky and you're trapping the tricuspid valve, with a floppier cable, you can push downwards more easily. Okay. Whereas here, if you push the cable, it'll be just straight up and down.
Yeah.
So we will release in shock.
Acquisition?
Yes, please.
Okay.
Doing an acquisition so you can see it better. Okay. Device is released and looks very nice on echo as well. Why don't we have a echo large now?
And we'll get an angio.
And get ready to do an angiogram.
Certainly the device looks well positioned.
Okay.
There is no major interference with the tricuspid valve. There is probably a small residual leak.
Yeah.
So we do an angiogram here. Step on forward for a second.
Okay.
Right.
Mario, we've got 1 minute with you.
Yep.
Okay, we'll do an angiogram.
Okay, go ahead.
And show us the angio large now.
Well, there is a lot of flow across the device as expected when we release and do an angiogram immediately afterwards. But I think the echo pictures are more informative at this point.
Yeah.
Kevin, what do you think?
Yeah, I think it was a mistake to do an angio. Now we're worried.
Well, we've been asked for.
I think we'll do an aortogram anyway.
Yeah, okay.
Whilst we're live with you, just pull the pigtail back for me.
Yeah, let's use a wire to take the pigtail back.
Yes, una guida.
Exactly, thank you.
Okay, otherwise...
It'll probably be all right, though.
Yeah.
Okay, John Thompson's got a question.
Mario and Kevin, can I ask you whether you think the risk of heart block is any less in these patients with a muscular margin as opposed to the true perimembranous defects?
Okay, we will reply separately. Kevin, what do you think?
I think less, but not non-existent.
Well, in our experience, we never had heavy block by using muscular VSD occluder. But, of course, the risk is not zero in any procedure. But so far, we have sinus rhythm. We didn't have any problem of rhythm, so we are confident that with this kind of defect, with this kind of device, the risk of heavy block is very, very low. Now we do a... No. We do an aortogram just to make sure we didn't cause aortic regurgitation.
Yeah. Okay, now we're in position. Okay, go ahead.
Go ahead. Okay, there is no aortic regurgitation at all. And I think if we have just 1 to 2 minutes, we will go back to the to the echo, and Carmelo will show us some 2D, 3D pictures of the device. Please go on with the echo large.
Yeah, well, what I'm trying to do now is to have a look at the device on 3D.
That's perfect.
You can see here I'm looking from the right ventricular side. And now to the left ventricular side. Here you can just see the opening of the subaortic region.
Gioca. Schiacciali per favore, please.
Thank you very much.
Okay, Shaq, are you happy? Any additional questions, comments for you from the panel or from the audience?
No, I think everybody is happy. That's an excellent demonstration, good result. So we're very pleased with that. Well done.
Okay.
We've got to go to Leuven next.
Stop
So, Mario, thank you
to
the whole team.
Okay, thank you very much.
Thank you, Shaq.
Bye-bye.